What we're going to do tonight is have three speakers. Each of the speakers is going to speak for 5 minutes, and then we're going to start a series of questions, some that I'll start to get the discussion up and running, and then others we'll take from the audience as we evolve over the next hour or so. As Pascal Questa has outlined, there's three speakers, and the first speaker is Mark Hutchinson, who's going to talk about addiction mechanisms. Mark completed his BSc majoring in pharmacology, microbiology and immunology at the University of Adelaide in 1998. In 2004, he was awarded the Fresh Science Prize for Communication of Science in the Media, and in 2007, the National Health and Medical Research C.J. Martin Fellowship. In Adelaide, he returned to the discipline of pharmacology in 2009, and 2011, he was awarded the Australian Research Council Fellowship for research into sex differences in pain and drug response. He's built and started his own laboratory in this discipline of physiology in the School of Medical Sciences, and he's now continued to gather grants. His publication record is outstanding, and he's secured funding from such diverse bodies as the Congressionally Directed Medical Research Program's Spinal Cord Injury Research Scheme. I have no doubt he'll keep us very amused and interested for the next 5 minutes. So Mark, I'll hand over to you.
So, what we're going to be talking about is the human brain. All of the addiction story, all of our behaviours, whether they be good or bad, originate because of neurochemicals within our brain, synapses firing, and electrical activity. Here we have some very nice, fancy pictures of flying through a theoretical brain. Apparently, this brain has a lot of space in it, and we know an awful lot about this brain. Our brains are filled with an awful lot of neurons, 10 to the 11 neurons, and so you can translate this to how many neurons this is. That's a lot of cells. That's a very, very big number. What we have is then thousands of connections by each of those cells to other neurons within the brain, creating even more connections and even more complexity. But I hope you've always wondered why there's this old wives' tale that we only use 10% of our brains. Surely if we've got fantastic brains, we shouldn't be using 10%, and hopefully the university teaches us to use more of them. But what is the other 90% actually doing if we only use 10% of our brains? And I run the neuroimmunopharmacology lab, and the big question I get asked is, well, what on earth is neuroimmunopharmacology? So I'll tell you the simplest story, and that's the neuroimmunopharmacology story, and then we can get into the complexity of the brain. Being trained at the University of Adelaide in pharmacology and then going off and training in the US in neuroscience, I understand now that, and training out of pharmacology teaches me that drugs we take to modify behaviour have their root of activity by modifying the brain neuronal system. And we term this the pharmacodynamic effect. Basically, these drugs, like antidepressants, like pain relievers, and drugs of addiction, modify the brain by modifying the wiring of the brain. But what I was exposed to a little bit, and then whilst I was training in the US, learnt a lot more about, was that we have ignored the immune system, both the peripheral immune system, the blood cells that people take out when you go to your doctor, but then the other 90% of your brain, which is immune cells. And what we understand now is that the immune system of the peripheral circulating immune system, as well as the immune system of the brain, can fundamentally change your behaviour and contribute to both health and disease. And so what my group are very interested in is trying to understand how drugs, which we once thought had their action directly in the brain, might in fact be having their action indirectly by modifying either the peripheral or the central immune system. And so this is neuroimmunopharmacology, by combining the understanding of these three domains. So what are these immune cells in the brain? 90% of the cells in your brain are immune-like cells. They are very, very important to maintain health as well as to the disease of the brain. So these are some pretty pictures of what these cells are doing in real time. Every 35 to 45 minutes, every single nook and cranny of your brain and spinal cord is checked to make sure it's doing okay by these immune cells. If there's a slight alteration to the health or maintenance of your brain or spinal cord, these cells will respond not as quickly as the electrical activity happens in the neuronal system, but it responds nonetheless to control and mop up and make sure everything's going okay. What this has meant is that people are now transitioning their view from what I'm calling brain version 1.0, which is the 10 to the 14 synapses, which, if we do the computer modelling, isn't complex enough to explain all of the behaviours and things that our brain actually controls in our everyday lives. A normal computer couldn't be doing what you're doing right now, sitting there. What we're looking at is this fascinating opportunity that glia, these immune-like cells of the brain and spinal cord, add fundamentally to the complexity of the brain and spinal cord, overlaying another 30,000 connections each cell to the already 10 to the 14 connections, making the brain far more complicated than we've ever appreciated. And in fact, just 3 weeks ago, there was a call in Nature to President Obama specifically to say thank you very much for spending $150 million mapping the connectome of our brains, but this is actually like trying to explain the world's transportation infrastructure by Google only looking at the bike paths in mainland Europe. Because the complexity of the brain is such that if these immune cells are not also mapped, we'll never actually get the complexity of the brain that we need to do to understand current pathologies that we're facing. So there's this call to map the other brain as well. So what's this got to do with addiction? Well, what we know about addiction is that it fundamentally, we can explain the neurochemistry of addiction quite well. We know that we love reward, we love things, we love food, we love sex, we love interacting with people, and we love learning things. These drive the normal, healthy, rewarding, we'll do them again and again kind of things. We integrate this information visually, sensorily, and this projects down onto very specific brain regions that I won't bore you with too much, but at the end of the day, it all comes down to the neurotransmitter that some of you may have heard about called dopamine. And this collectively is called the corticomesolimbic dopamine reward pathway. Big mouthful, but very important for your survival. And you wouldn't have got this far through your life if you didn't have a corticomesolimbic dopamine reward pathway. What do glia do to this? Well, they fundamentally change the entire corticomesolimbic dopamine reward pathway. And there's not one part of this pathway that the immune cells can't change. And yet we've only realised this in the past 3 years. What we now understand is that this immunological changes supports and promotes addiction within this part of the brain. And so we and others are now doing research to try and correct this problem in the brains of people with opioid and methamphetamine addictions. And a nice quote that we got from the AMA president was that we're doing an absolute breakthrough when we published that we were able to treat heroin addicts by targeting the immune cells of the brain. And we've also got promising data out from California that we can treat methamphetamine addicts as well by targeting these immune cells in the brain. This is a paradigm shift in terms of our understanding what is actually underlying addiction and dependence. So I'll leave it there.
Thank you very much. The second speaker is Paul Del Fabro, who's an associate professor in the School of Psychology. He's been researching gambling since the mid-1990s, ever since the introduction of gaming machines to pubs and clubs in South Australia. His area of interest has been prevalence, social impacts, as well as the cognitive and behavioural factors that maintain gambling behaviour. The big controversy in gambling for him is trying to establish to what extent is a bona fide addiction and what elements constitute a behavioural addiction or an addiction more based on a disease model. Paul, I look forward to the conversation.
Yep, thank you very much for that introduction, Justin. I'm off to pump this up a little bit higher. There we go. Trouble being tall. Okay, yes, my principal area of research is in the area of pathological gambling, or problem gambling, as it's often called in the media in Australia, and also behavioural addictions, which is quite different in many ways from the topics that I guess Robert studies as part of his area of research. So what I want to do today is talk a little bit about what a behavioural addiction is and how this differs from a traditional substance abuse addiction. Because it's been a very topical area. Nearly every day you see some new addiction identified in the media. So I want to talk a little bit about what an addiction looks like from a behavioural point of view and where we might draw the boundaries. So a few comments about gambling. It's probably not as big a public health issue as drug addiction or alcohol, but from an economic point of view, it's a massive industry. People lose $20 billion a year on gambling out of pocket. So at one stage it was bigger than the mining industry until the mining boom occurred. So it's a huge industry. Around about 70% of the population gambles once a year, so it's a very popular activity, very normative. But only about 10% of people gamble once a week. And only about 3% of people play pokies once a week. And we know that 60% of that revenue comes from the pokies, which means that of $12 billion, only about 3% of the population actually contribute that. And a lot of these people are problem gamblers. Pathological gambling was recognised as a psychological or a psychiatric disorder in 1980 in the Diagnostic Statistical Manual for the Psychiatric Disorders. And it's been pretty much the criteria for pathological gambling modelled upon substance abuse. So when you read about pathological gambling, you'll read about the same sorts of processes you'll read about in traditional addictions. You'll read about tolerance, people needing to bet more and more to gain the same excitement, withdrawal, feeling very bad if they stop gambling, and cravings, strong urges to engage in the activity. But the real controversy with gambling is that it's often been called the dependence without a drug, because where's the mechanism? With alcohol, we can say, well, there's ethanol in it. With marijuana, there's THC. There's some sort of active mechanism. With with gambling, on the other hand, there's no obvious mechanism. This is why the sort of work that Mark's doing is very important, because until now, really, it was very hard to draw parallels between the two. There's been a lot of research suggesting that some of these classic addiction processes probably are present in gamblers. But when you actually read a lot of the research, you find it's not quite the same. There's not a lot of evidence that pathological gamblers experience the same strong physiological withdrawal and pain that you see in addicts to drugs. Instead, it seems to be more of a form of psychological dependence, where people will feel bad if they don't gamble, they feel bad when they stop gambling because they are disappointed by losing. They often feel depressed because of what happens when they're gambling. So there's been a lot of, when you look at a lot of psychological research, there's certainly some parallels, but you don't see the same physiological arousal in gambling. We have the phrase poker face for a reason. Most pokie players, if you see them, look like they just got off a Qantas flight from Dubai. They just sit there, just pressing the button very slowly. There's not a lot of arousal. A lot of studies suggest that, who've done physiological studies. And of course the danger is, with this type of research, if you start to sort of soften the criteria, where do you start to draw the line? And so one of the very interesting areas we look at in our research is where you draw this line. What do you look for to identify a bona fide addiction? A lot of people have talked about, for example, video games being a form of addiction. Many people have teenagers will say, I never see my teenagers. There seems to be some elements of it. Can you be addicted to the internet, for example, or chocolate? There's lots of debates about these sorts of things. So what do you look for to get more convinced that you're looking at an actual addiction as opposed to something else, simply just a very excessive behaviour? The sort of things you look for is harm. Is there a genuine capacity for clinical damage to be done to the person as a result of engaging in the activity? Does it break down families? Eating too much chocolate probably won't. Is there impaired control? This is one of the fundamental components of behavioural addictions. Has the person lost the ability to make reasonable decisions about their behaviour? Do they no longer have the ability to sort of resist the urge to gamble and stop when they start? And is the behaviour increasingly driven by sort of lower level sort of emotional processes rather than sort of clear the rational decision making? These are the sorts of things we look for in establishing a behavioural addiction. And what we call loss of stimulus control. A pokie player won't be able to drive down the street without getting a sense of anxiety, because they'll see symbols of poker machines everywhere. They'll see hotels, they'll see signs, they'll see money. That might be enough to get that urge happening. And so a lot of the focus on our research is based on what's called sort of the interactionist or ecological approach. We argue that there are certain people out there who probably are more vulnerable to developing gambling-related addictions. And we'll hopefully get an opportunity in the question time to talk about some of those vulnerabilities. But we also argue that there are certain characteristics of activities which make them more likely to be amenable to addictive-like processes. In other words, even though theoretically you could get hooked on carrots or watching soccer, it's more likely that there are certain activities that are more likely to form addictions. And these are the characteristics they tend to have. A capacity for repetition, where there's an ability to engage in the activity very frequently, where there's a short gap between the behaviour and the outcome, and where there's a very strong reward value, where the brain gets very excited by engaging in that particular activity. If it's a very boring, flat activity, then that probably won't happen. And also where there's a greater capacity to generate harm, and where you can get more emotionally involved in the activity. And gambling has those characteristics because it's all about money. People lose a lot of money gambling, people want to win money gambling. Whereas chocolate, might be nice to eat it, but you can see that there are many of those characteristics that are not true of chocolate. Now, hopefully, in the question time, we'll have a chance to talk about some of these things a little bit more depth. So I hope that's a useful introduction to behavioural addictions. Thank you.
The third speaker tonight is Associate Professor Robert Alai, who's a public health and addiction medicine physician who has worked in alcohol and other drug areas since 1985. Associate Professor Alai is the director of DUS's WHO Collaborating Centre for the Treatment of Drug and Alcohol Problems based in the School of Medical Sciences at the university. Professor Alai is a member of the WHO Expert Advisory Panel on Drug Dependence and Alcohol Problems. He's also a member of the Cochrane Drug and Alcohol Editorial Board. I'll hand over to Bob.
Thanks very much, Justin. My area that I'm going to talk about today is focusing on illegal drugs, and I particularly want to concentrate on heroin addiction. It's a very uncommon problem. We only have about 0.2% of the adult population who are addicted to heroin, but it's something that occupies media attention and interest all the time because of the huge health, economic and social harms associated with it. So in this state we've got about 6,000 dependent people, and often politicians are concerned about it enough because they see it as the most addictive drug that we have. But you can see from Jim Anthony's work that in fact tobacco has a higher rate of ongoing to dependence, with only about 1 in 4 to 1 in 5 of those who ever use heroin going on to becoming addicted to it. What I want to focus on is the issue around Cochrane, which is a group of like-minded people who've come together to try and sift through and understand evidence. So their job is to bring together randomised controlled trials and case-controlled studies, aggregate that data together and make sense of when we know whether something actually works or when we know that it doesn't work and we shouldn't continue to do it. The Cochrane Group for Alcohol and Drugs has been around since the late 1990s. I'm part of the editorial board, and we in Adelaide are responsible for 6 of the reviews, and particularly our interest relates to that of dealing with the addictions to opiates. You can see that's dominated most of the work that our group has been involved in. We've looked at opiates as well as alcohol. Psychostimulants has been an emerging area, particularly around methamphetamine, and we might get a chance to talk about that during the discussion time. There have been 22 reviews that have occurred within the area of opiates, and I'm not going to go through all of them. They're colour-coded and will be available in the slides afterwards. Yellows are the treatments that are dealing with the treatment, long-standing treatment of opiate addiction. The maroon colour is to deal with the management of withdrawal, and the white ones are the behavioural addictions. So you can see the vast majority of the work has been done in either how best to manage opiate withdrawal or how to manage it as a long-standing treatment problem. I particularly want to concentrate on those studies that have been involved that are in the yellow code. We've reanalysed that data and aggregated it in a different way. And what we've done is pulled together by looking at confidence of effect to identify a traffic warning system of appraisal. The green are those where we're confident that it actually works. Red, we're confident that it doesn't work. And the white area, we're still uncertain. Work needs to be done. You can see that almost a quarter of them, we've now got enough evidence to show that there are things that are being done in routine clinical practice that don't work and we shouldn't be doing it anymore. And what we're trying to do is to grow that area of green. The work that's predominantly shows that as works relates to opiate substitution treatment, methadone and buprenorphine being the most commonly used evidence-based effective treatments that we have, and that work is enhanced by linking them to psychosocial interventions. What we have found, however, is that most of the work that's been done has been on the pharmacological interventions, and very few of the published data on psychosocial supports are yet to be incorporated into Cochrane reviews. So we believe that that's an area which shows promise and is likely to show benefit in the revisions of those reviews. WHO has been so impressed by the evidence from Cochrane that it's made both buprenorphine and methadone essential medicines on their essential medicines list. The work shows that it reduces health and social consequences, reduces crime, and improves the social reintegration of the individual. All of those effect sizes are statistically significant, and that holds true both for methadone and for buprenorphine. But what we find is that the treatments aren't being taken up, and they're not being taken up in primary health care. We've only got about 50% of people in treatment in this state, so there are about 3,000 of those 6,000 dependent users who are currently in treatment. The vast majority of them are being treated in general practice. We've got 65% of them being seen by GPs, 70% of them being dosed in community pharmacies. But at the moment, we've got less than 6% of GPs who are actively involved in providing this treatment, and we've only got about a third of community pharmacies involved in this treatment. So I guess the question is, why? Well, the majority of it is because they don't think the treatments work. They've got a very fatalistic view of the effectiveness of treatment. They see it as a complex, time-consuming thing, and they don't like the idea that drug addicts would be treated in their practice because they're scared that that's actually going to displace their other patients out of their treatment system into other healthcare practices. So the vast majority of them keep away from it. I guess that however, it doesn't take Einstein to realise that actually these treatments don't work on the first occasions, and often what we see is that people require 3 to 4 episodes of treatment for them to get a net effect. And it's about the long game. It's about staying involved in their treatment. One study that we've looked at found that the drug addiction career is on average about 27 years, and that people have to cycle through 3 or 4 episodes for them to get substantial changes. Where our group is now concentrating its efforts is that we know about 40% of people who enter treatment rapidly respond. What we don't know is what separates the rapid responders from those larger group who fail to respond. And we think there are genetic markers that relate to medication sensitivities and prototypes for change, and Mark's work is also helping us to understand it. So our investments now is trying to understand how we can accelerate that larger group who fail to rapidly respond into treatments by more selectively matching them to the treatments that are likely to work for them. Thank you.
Thank you. Thank you, Robert. I'm going to ask the 3 speakers to come and sit at the front, and we're going to open up for some questions. What a fascinating journey from basic science through to behavioural traits to actually medications we use to deal with addiction. So I'm going to take Chairman's privilege and ask a couple of questions from each of them, and then open it up for the rest of the audience. Paul, in your opening comments, you suggest that the causes of pathological gambling are likely to be influenced by a variety of factors, and some people are possibly more vulnerable. Who, from your perspective, is most likely to develop problems with gambling?
Yeah, research over the years has thrown just about every psychological theory under the sun at this topic to try and work out this question. I think the general conclusion now is that problem gamblers are certainly not an homogenous group of people. There's different pathways into pathological or problem gambling. These pathways are probably not necessarily entirely not overlapping or distinct. But the 3 sort of principal pathways you see in Australia, if you're working, for example, in treatments and you had clients coming in with gambling problems, the 3 sort of patterns you tend to see are the following. The first group, who tends to be more male than female, tends to be a group of people who grew up in families where there's a lot of gambling. They're the sort of young people you meet in the schoolyard who always got some sort of racket going, running a sort of betting sort of thing on the side. They're always on the mobile phone. They've got their stock trading laptops. They believe they've got some system for beating it, beating gambling. They read up books on how to beat roulette. These people tend to end up spending too much money, chasing their losses, and they get locked into the whole pattern of problem gambling without necessarily having any underlying problems before that. The second group of people, a very common group, where you see more women than men, is people get hooked on the poker machines because of depression and stress and anxiety. So quite a few people, we've done a lot of research here at the university which has looked at the trauma histories of people who've had problems with poker machines. And what we find consistently is a lot of people who develop these problems have histories of child abuse, often difficult marital situations, difficult traumatic employment situations, quite difficult lives, which often then translate into depression and anxiety. And often poker machines have performed the escape. They've gone out with friends to start playing, and then they've stayed behind, and the whole cycle has started. So otherwise, gambling is a form of coping, emotion-based coping for these people. And often all the treatments which we look at involve dealing with this depression and anxiety, which drives the underlying gambling problem. The third group of people, who are probably very much interest to Mark, are people who you see with multiple problems. We've done some recent work looking at regular gamblers, and most of these people, when you do a full psychiatric assessment, they tend to have a lot of other problems, personality disorders, other underlying psychological comorbidity. They're more likely to have problems with alcohol. So we suspect there's a certain group of problem gamblers out there who are probably vulnerable right from the outset. They're more impulsive, more antisocial sometimes, very difficult to treat. And these are the sort of people where there may be some genetic underlying neurophysiological reason why these people are more prone to addictive-like processes.
Thanks, Paul. That sort of moves nicely to Mark, so you can see. So building on that discussion around dealing with the third group of people, what are the future treatment options for drug management of this type of addiction? And where would your research go over the next sort of 5 to 10 years as you build this understanding?
Yeah, so there's a couple of approaches that we've been actively pursuing. There's trying to identify the immune genetics predisposition to people going to have an addiction whether they like it or not, born with the propensity to be a drug addict. And we've done some really interesting work with both opioid, so that's heroin and pain-relieving drug abuse, as well as alcohol addicts. And what we've found is that there are immune genetic polymorphisms that predict for both alcohol and opioid addiction, even though they're very, very different abuse classes of drugs. So we're now able to identify people who are at risk just through immune genetic differences. Through collaborations that I have with a colleague at Duke University in the US, we've identified that early life infection or early life maternal care can fundamentally change the immunology of the brain, and that leads to lifelong alterations to somebody's, somebody being a preclinical model of addiction, being predisposed to abusing drugs like morphine and codeine and cocaine. And so we've been identifying new ways we can try and reset the brains of adults to change their immunology so that they're not going to be addicted anymore. And the third option is trying to, it's hard now in New York actually to get heroin addicts. There's hardly any heroin addicts because they're all on oxycodone, OxyContin, because it's perceived as safe. It's hillbilly heroin. And this is not the opioid addicts shooting up in the back alley. It's the very wealthy buying or getting a painkiller off of their friend's mother's cousin's aunt, who then dishes them out to everybody else, and they have it over a glass of red wine at night with their friends. This has changed the perception in America of what a drug addict actually is in terms of opioids. And so the opportunity we have now is to make safer, non-abusable opioid painkillers. And that's a long task that we have ahead of us. But by making opioid analgesics safe, they work better in our models, and they aren't able to be abused because we just don't see the same activation of the reward pathways. So in the future, we've got those opportunities ahead of us. I guess the one challenge that I think we do have, and fortunately the US politicians, when they go to work, they have identified that actually the drug dealers and drug manufacturers are very much with their finger on the pulse of the science. And our research, any research into understanding the mechanisms of addiction, identifies both cures, but at the same time points out how to make things more addictive. And our immunological work opens up a brand new avenue for drug manufacturers to make their product even more addictive and even more effective at creating a clientele. So in the US, they're actually starting to look at these policy options to make the law flexible enough to deal with these rapidly changing, well, soon-to-be problems in having a drug of abuse mixed with an immune stimulant, for example. So these are exciting opportunities to be involved in and actually working at the ground level.
I think we'll have to keep an eye on you, Mark, over the next 15 years, because you could be very wealthy. Robert, well, I'm really interested in the issue of people as they start to recover from drug and alcohol problems. And what are the sort of key measures you see with people who can actually get remission and recovery and stay permanently off the addiction? What are the sort of risk factors, or what are the markers of people who can actually move past that journey?
There's been a lot of work looking at trying to identify what helps build resilience to stop people from using drugs and how successful they can be. The long-term studies that have looked at complete cessation from drug use have shown only about 20% are able to manage the complete abstinence. And about another 20% continue to use drugs, but nowhere near at the same damaging level that they were using it before. Around a half of them, however, for heroin are dead. So in a 30-year drug-using career, it's a very risky business. And certainly Mark's right, in the shift over to known products like OxyContin, one of the major things that's been removed has been the uncertainty of the potency of the drug that people use, because a lot of the times people would die from overshoot, that they injected a drug not realising how strong it was, and they ended up dying as a consequence of that. The key things that I think we've tended to focus on in terms of preventing continuance of drugs has been the therapeutic environment. And most of the research shows that it's the quality of the therapeutic relationship which accounts for most of the variance within the treatment. So what you do isn't as important as the way in which you do it. The area, however, where we've completely undervalued has been those things that happen outside of the therapeutic engagement. And that relates to family support, it relates to social connectedness, it relates to reintegration, getting out of the drug lifestyle behaviour. A lot of the work that's occurring now in the United States, and our group is starting to do work on this as well, is how you build resilience by tapping into those resources that we used to actually block and not allow into the therapeutic engagement. So it's about reconnecting them to the family, reconnecting them to non-drug using peers, and getting them back into having a productive life in the workforce. Those things, I think, have been completely underestimated, and what we've been more focused on has been the connection point of the medication treatment compliance. Those, I think, are the big windows for us to work on in the future.
Thank you very much, Robert. I'm now opening up for people from the audience who'd like to ask questions. If you put your hand up, there's a roving microphone, which Jess will walk around, I think.
My question is to Mark. I'd just like to know how you go about resetting an adult brain, please.
So there's a couple of opportunities we have open to us, and my wife's a neuropsychologist, so I always put in the plug first for the psychology angle, because probably one of the best ways to reset a brain is actually with the talk-based therapies. And when I say talk-based therapies, I mean the counselling, psychology, cognitive-based therapy, mindfulness therapies. There's work from the 70s and 80s showing that somebody who has a mindset, method actors who have the mindset for 2 months of a depressed person end up with an immune system of a depressed person. And then when they go through cognitive-based therapy, their immune system resets to their healthy level again. So it's as simple as thinking the way you want your body to think. So that's one way. But unfortunately, Australians don't like talking about their emotions very much, so we're always looking for that tablet to pop because it's easier. So the other alternative is a drug-based approach, which will always work better when it's combined with a talk-based therapy. And that will be a drug that targets the activated immune cells within the brain. And we've already entered clinical trials with those agents in the US, and this is where we're seeing promise in opioid withdrawal and methamphetamine addiction. So hopefully we can roll those out or roll the better next version of those ones out in the future.
Thank you. My question's two parts, and it kind of goes on from that last question. For process addiction, such as gambling, sex addiction, and what have you, are there any, or is there any research around the genetic markers of those addictions? And secondly, if there are there any pharmacological efforts at the moment to go through for the process addictions?
Yeah, some of the work, there are good, there's good evidence out there for genetic markers of addiction for those behavioural approaches. And those, we've done some work in the immunology world, but there's also some around the reward neurotransmitters and reward receptors, dopamine receptors, for example, and dopamine transporters, and also the stress response system has also been implicated there. But in terms of drug companies spending big money in developing these agents, it's not an attractive area to be working in. You don't necessarily want to be sending all of your development money down the line of an addiction when you could be treating 2/3 of the population with blood pressure problem or fancy little blue pills for men. So it's not an attractive area to go into. The exciting thing for me has been to see the US government put up their own money to sponsor these trials that I've been involved in, off their own bat, saying, we want to make drugs to help our, Department of Defense are putting in some money, the US NIH putting in money to say, we want to make these drugs available now because this is a problem. NH and MRC, I'm sure the Australian government would love to, but we're talking a lot of money. It's $100 million to run some of these trials, and with the current budgets, the money's just not there. But some of the other guys want to have some...
Yeah, there have been things like naltrexone trials for gambling. I mean, the fundamental problem in some of these trials is just getting people to come back and getting in compliance with the trials. I know there was one here in South Australia, and I think that was quite difficult to do because of there has been some genetic studies of gamblers as well. But like I was saying before, that you tend to find only about, if a particular gene's identified, it's only about 40% of the problem gamblers will come up as having the gene, which suggests, once again, that there's probably other reasons why people become problem gamblers. Certainly a genetic predisposition for certain people, but not for others.
Surely the Australian government's feeding recently millions or hundreds of thousands into clinical psychology rebates would provide the medical profession with a brilliant opportunity to humble themselves and hand over a lot of the load to clinical psychologists.
At this present time, most of the gambling treatment does involve clinical psychologists or counsellors. So in South Australia, for example, we have the Gamblers Rehabilitation Fund, very similar models across the country. The industry makes either a mandatory or voluntary donation to the government, which is then managed, and then apportion the funding to different types of services. And clinical psychology is certainly one of the services which are supported by that. There are clinical psychologists working in the problem gambling services. But a lot of it's also based on financial counselling. The very first thing a problem gambler needs when they come in for treatment is to get out of jail. So financial counselling is very important too. So it's often a very multidisciplinary approach to that, but certainly it is the case that psychologists are involved with the treatment at the moment. Yeah.
Can I ask Robert to talk about how you turn the negative connotation or the negative perspective of this issue to a positive one of rehabilitation and moving forward? Because as a practicing general practitioner, that's a very good comment from the psychologist that's saying it's very difficult to go past the negatives and not move to the positives. So what do we need to do as a community to really start to move it forward in a positive direction?
Well, I think a big part of it is about changing the stigma. I think that people admitting that they've had a drug problem, whether it's an addiction to pain medication or addiction to heroin or cannabis or any other drug, brings a large amount of stigma. So what happens is when people have recovered, they disappear. And so there are no role models, there's no champions standing up saying, I was able to get over this. So the overwhelming perception that the communities and general practice gets is that treatment never works. I think that's probably one of the major things that we need to be able to do, is to pull this out of the cupboard and start allowing people to stand up. When Bob Hawke in '85 cried on television about his daughter's heroin addiction, he did something about it. He injected a lot of money into drug treatment programs and championed it in a way that has been hard to sustain. But that took a lot of courage on his part to stand up and say, she needs help and something needs to be done. We don't hear the end story though. What happens when people have recovered, they disappear. I think we need to change that.
Oh, hello. I have a question for each of you, actually. Firstly, I was curious that drugs such as amphetamine and Parkinson's drugs that cause gambling wasn't actually mentioned in your talk. And the second one is to Mark. So are you suggesting that there will be codeine or whatever can be taken by people and they won't actually have that same pleasure response to want to use it as an addictive thing? And thirdly, naltrexone, I saw it mentioned in one of the yellow type things, but I had a thought that it was actually better than methadone as far as treatment compliance. What do you think about that?
Perhaps we start with Robert with the last question, and then Mark, and
well,
then Paul.
Naltrexone's a great drug. It has high efficacy. The problem is people stop taking it. And the reason they stop taking it is because it's not doing something, it's preventing something from happening. So it blocks the effect of opiates, it very strongly binds to the receptors and is not easily displaced. And people lose enthusiasm to take it. So the next step forward in that treatment journey was to look at sustained release preparations, and there are two alternatives. There's an implant which is being used in Australia but hasn't yet received registration as a product. And there's injectable depot forms which are being used in the United States and again haven't been registered here because we're not seen as a large enough market and the companies don't want to go through the registration process for such a small group. Both those products have been shown to have better retention because they last at least 30 days. Once you've got the product on board, there's not a lot you can do to change that. And in fact, that seems to have overcome the hump because we know for naltrexone treatment, you need about 3 months in treatment for it to be able to have sufficient effect for it then to be a sustainable traction for you to change your behaviour. So in those terms, both of those opportunities seem possibly good. The implants, jury's still out because safety and efficacy data isn't in yet. And the depot preparations, we've been encouraging the manufacturers to register it here, or at least allow us to do clinical trials to show it works here, but they're reluctant to do that.
So in terms of the new drugs, yeah, the idea will be to have a new version of codeine, which isn't codeine, but that still binds to the same receptor in the body that codeine binds to, but doesn't do all the immunology combined with that we're seeing with the existing drugs. There's a company in the US who fortuitously made one of those drugs that we pointed out to them that they had made it and they hadn't realised they'd made it, and they went back and did the studies and showed that, sure enough, their drug binds wonderfully to the opioid receptor and creates fantastic pain relief. But in their studies, they couldn't see it being abused or any dependence being formed to it, which was really exciting because it's proof of concept that actually this kind of approach of a purely neuronal focus rather than muddying the waters with the immunology is an opportunity to clean up pain treatment.
There was a third question you asked, which was the Parkinson drugs.
Yeah, just to say I'm aware of that research. It's not something I've had a lot of involvement with, but yeah, I'm certainly aware of the fact that Parkinson's drugs can lead to pathological gambling problems. Yeah.
I've used heroin for 27 years, and I've had actually 5 naltrexone implants, and the effect absolutely wonderful. I've been clean for 5 years, but it doesn't. I still have a problem with gambling though. So hey, works for some things.
It's not a silver bullet.
Thank you very much. It's a fantastic comment. Thank you very much.
More questions?
Just while we're getting across, I just want to pick up a question that's important to my sons at the moment. How important is technology and addiction? Is it really true that a person can become addicted to the internet or video games or whatever happening in my current house at the moment? So,
yes, the Premier is very interested in the same topic because of he, like I, have both got small children under the age of 10 who can remarkably spend $20 right under your nose on iPads without actually entering a poker machine venue. So it's a lot of interest in that topic at the moment. Yeah, technology is very important. It's extremely important with in relation to poker machines, for example. I mean, something like 80% of gambling-related problems are caused by poker machines, probably 90% in females, probably about 70% in men. And a lot of this is to do with the fact the way the machines are designed. It's not necessarily the case. You've got psychologists out there who've turned to the dark side and working for the game machine manufacturers. The manufacturers I've sort of spoken to assure me it's a myth. But I have met some psychology lecturers from UCLA have told me their PhD students went off to work for a manufacturer over there. So there may be some, and they were rat researchers, so you can sort of see the parallels. It's certainly the case that subtle differences in the way these machines are designed can make a big difference. And that theoretically, you probably, like Michael was saying about, you need to learn how these machines work to understand the problem. You probably could create the poker machine of death if you were to sort of get certain features and put them all together, like have a machine where you can feed in sort of banknotes and which plays very fast. So certainly certain features of these machines which make them very, very attractive to people. The sound combinations, the lights and colours are very, very important in making the machines very attractive. The marketers often don't know which one's going to be successful beforehand when they put them out there, but I sort of get some sense of which ones probably make the machines work. In relation to the internet, internet's an interesting one because it's not necessarily an activity in its own right. It's a conduit for engaging in other activities. So a person who spends all their time on the internet could be addicted to online video games, and particular ones which they tend to get hooked on are these World of Warcraft, RuneScape, these massive online role-playing games which people can play for months and months and months. And it sort of taps into all that sort of classic sunk cost psychology where you devote all this time and effort to it, and then after doing it for days and weeks, spending hundreds of dollars, not thousands, you sort of want to keep on going to finish it. And so young people get hooked, disappear in their bedrooms for months on end to play these games. The internet can be also a conduit for other activities, other problems. A person might be hooked on pornography, for example. So pornography might be the primary problem, not the internet. The only sort of activities you see which are perhaps unique to the internet are things like obsessive use of social media. Some people get into the, compulsively blog. They compulsively use Facebook. They just can't sort of bear the thought of not knowing what's happening with all their friends all the time, so they spend all their time doing it. So that's a uniquely online activity. You could argue that some of social media stuff might be not necessarily an addiction, but close to the sort of activity which is unique to a uniquely internet-related behaviour, which is new, something we haven't seen before.
Thank you very much.
Sorry, my question was to follow on that thread about the perception of drug abuse or any abuse and how much that interferes or affects the reality of cures. I was just halfway through David Nutt's book, The Politics of Drug Use in the UK, and one of the points he makes, I guess, is that objectively many of these addictions are not perhaps as bad as people think they are, or certainly as bad as they're portrayed. And therefore I was just wondering whether you'd comment on, in Australia, how much our perception of the problem is skewing the way that we address it and treat it.
It's interesting. Every Minister of Health that I've ever briefed, the first question they ask is, how many do you cure? So their conceptualisation of the problem is it's akin to the common cold, not akin to diabetes or hypertension or epilepsy. So they don't have the idea of a chronic disease, and they certainly don't have the concept of a chronic relapsing disorder. So their belief system is influenced by that. It's also interesting that as a community, we have a perception that they can't ever do well and that they can't engage meaningfully in treatment. So our paradigm is us and them rather than them being part of our community. And so they get extruded because of that. In fact, when people have looked at compliance rates for treatment, their compliance is comparable to people who have epilepsy, diabetes and hypertension. They do all the things that we would expect. So sometimes they don't take medication as directed. Sometimes they want to test themselves out and see whether or not they really need that asthma medication, or with the diabetics who stop taking their insulin. So all those behavioural characteristics for those diseases are seen as normal in that group, but somehow we demonise this group. I guess that the biggest problem, however, is that media play a very big role in what we see as problems. So if it's on the front page of the paper, then we start to believe that it must be serious and it's real. And if the media calls something an epidemic, then as a scientist, I've got a view of what an epidemic is. But of course, most of the reporters aren't scientists, and they use words in lay terms to create fear and anxiety. So if you were looking at the newspaper and you saw that there was an epidemic of people who had turned up in our hospital system because they had taken an illegal drug, you get a sense there must be hundreds or thousands of them. Well, actually, there was only 20. And those 20 people all took the drug in one setting, and they all took the drug believing they'd taken one thing when actually they'd taken another. So the research chemicals that are around at the moment are going to be a real challenge, because as new research chemicals come on board, the media is going to promote this new epidemic and the feeling of loss of control, that we've got a new problem that we can't manage. And it's actually just criminal networks experiencing the opportunity to sell research chemicals to new audiences that find out that they're particularly dangerous and they stop using them. I think we need to get ahead of the curve on this, and we need to represent it as it is unusual behaviour. When it does happen, it can have catastrophic consequences, but we can prevent those catastrophic consequences by more realistically portraying what happens.
Can I ask Paul and Mark whether you want to comment on the issue of the perception and how it can be changed and moved?
Yeah, certainly with gambling, it's an interesting topic. The advertiser has had a long interest in looking at gambling, and there's been lots of stories over the years. I think one of the areas I looked at many years ago was adolescent gambling. What you typically find with adolescent studies is the problem gambling rate is higher in adolescents than it is in adults. Yet relatively few adolescents come in with gambling problems. And I think the reason is that you find that many of the adolescents will show all the signs of pathology. They'll be preoccupied with the activity, they'll be engaging in it quite frequently. They often don't experience the harms that the adults experience. And so I know from the media point of view, there have been stories run which have talked about this epidemic of gambling problems in adolescents, which is certainly a very important topic. A number of problem gamblers do have problems as adolescents, but often the harms aren't as great, and so the problem, I think, to some degree was being exaggerated. So I think there's certainly the media can play a very, very positive role, I think, in drawing attention to problems. But I think at the same time, you have to sort of be very cautious about what you read at first instance when you see some of these stories.
Yes, from a basic scientist talking about changing perception, that just talking about how the brain actually works, people are surprised at how it works. I mean, we hear about these ideas that the brain is a computer, and so we immediately start thinking about our computers and reformatting the hard drive and installing new firmware and doing software updates. But fundamentally, the computer's the same thing, and it hasn't actually changed. You've just put different bits and pieces on the hard drive. The memory's basically the same, the monitor's the same. So if you wanted to, you could easily reset that. Your brains coming in here this afternoon are going to be fundamentally different to the brains that walk out of here, and that you can't undo what we've done here and now. And so at a biological level, that's really fascinating, because we're an organic brain, and so just experiencing what we're experiencing now changes the structure of our brain, the proteins that are in our brain, the various minerals that are in our brain on a continual basis. So getting that across to people fundamentally changes the idea about what a disease in the brain actually is. We can't simply just say, get better, you'll be fine, there, off you run with these tablets, because the brain has to unlearn and then relearn to be a healthy brain again. So when we're talking about addiction, that's a lot of brain sensors that need to change and adapt. And there's no set playbook or instruction manual that comes with the brain for the brain to reformat and reboot and off we go again. And it does that on a spontaneous basis, and sometimes it gets it right and sometimes it gets it wrong. Sometimes it makes it worse. And the brain needs to iterate through over time to get itself better again. And unfortunately, we don't know yet how to properly direct the brain to say your brain is going to go in the best direction, and that might be the 40% of people who respond very positively to treatments, but the 60% of everybody else, no idea. Their brains are perhaps pointing in the wrong direction and heading off, completely 180 degrees. So that's what really we're looking towards now, is trying to understand more about the basic science, the basic cellular experimental work, which we can then build up in a much more complex pattern to then say, now we understand, now we can have greater success rates by doing simple things like integrating family in with the treatment program. It sounds simple and common sense, but it's not actually necessarily commonplace. Or simple things like substitution therapies, making them available worldwide. Those things aren't available to a lot of our drug-addicted brothers and sisters around the world because it's deemed as not worthwhile, not good money to be spent, public money spent on a problem.
Just remember, we've all had changes in the last hour and a half, so I look forward to leaving. The guy at the back, please.
My question's for Robert, and it sort of leads on from the response to the last question. And Justin, although you're not part of the panel, you might have some comments to make on this, given your interest in primary care and health financing. Because I'm a primary health care practitioner, and I recognise that we are part of the problem here, that even though there is all this research emerging about the efficacy of treatments for addiction, that the primary healthcare system in Australia is not really meeting the challenge. As you said, Robert, we are getting better at managing things like diabetes, and the primary healthcare system is taking up that challenge, but it doesn't seem to be taking up the challenge adequately of managing addiction. So I'm just wondering if you have any thoughts on what can be done to influence the primary healthcare system in Australia to become more responsive to the needs of people with addictions.
Well, I think there are a few things that we could change to make things better. Firstly, I think services like the one that I run should be providing a better step care model than we currently do. So primary health care is about managing things in your world, and that when they become complicated, knowing that there's a specialist service that you can refer on to for assessment, stabilisation and perhaps co-management or taking over the care. I don't think we do that as well as we could. I think there's also a problem in the healthcare system that it doesn't adequately get remunerated for the complexity of managing these people. So one of the real barriers for access into treatment at the moment is that if you're in a methadone or buprenorphine program, you're the patient, you're paying a third of the healthcare service delivery costs, and you're paying that to the pharmacy service. So we should be actually doing something to offset those costs, and the Commonwealth could do more to address that. But I think probably the biggest area that I'd like to see primary healthcare getting involved in is getting in early. At the moment, talking about tobacco is seen as core business. Everybody in primary healthcare would expect the GP to ask the question, would expect an intervention, would take the opportunity when there is a presenting complaint that could be tobacco related to do something about it. But that's not the case for alcohol, and is definitely not the case for illegal drugs. And I think that part of the reason is that in primary healthcare, you don't want to ask a question if you don't know how to deal with the answer. And at the moment, feeling confident that you could identify an early problem and do something that's quick, easy and effective is a really complicated path in primary healthcare. So I think what we should be doing is building the confidence to ask the questions early and to know that the answer is really helping the person to come to grips with what they're doing, which is a cheap and effective way to do it. Addiction treatment returns $7 for every dollar you invest in it. But at the moment, I think what we do is we wait until the problem has become so big, so complicated, so obvious, that it actually then requires special service like the ones that I run.
And just to add, there's other solutions, but I think the key thing is to start with education, and you start with the graduates and build the positive story, not the negative story about this. We have time for one more question at the back, I think, please.
Yes, thank you. I'm an alcoholic who first addressed the problem of alcoholism 20 years ago, and I believe things haven't progressed terribly much in 20 years. I was wondering what has been done at the coalface. This was addressed in the last question, especially the medical community and especially GPs. I believe that addiction is a multifaceted problem, spiritual, physical, emotional or social, and mental. Recently I have decided to go down the pharmacological path, and I believe this is a very positive way to go, but I had to seek that kind of assistance. It wasn't readily available. I'd like your comments. Thank you.
Okay, so I guess you've raised a few issues that are important. I probably haven't placed enough emphasis on self-help, and AA has been a very important contributing factor to many people, assisting them in recovery. But the medications that we now have for treating alcohol addiction, acamprosate and naltrexone, are safe, effective, they work, but less than 10% of people who are eligible for that type of intervention actually get prescribed that drug by their GP. So one of the reasons that that happens is because the general practice often aren't aware that it works, or it requires an authority process to go through, and that can be confusing and a barrier in its own right. So there are medications that are safe and effective that work. Self-help is one of the things that we actively encourage because the two can work cooperatively together. And of course there's the counselling that's available, and we've already heard about the fact that there's a psychology workforce now that primary healthcare can draw upon to assist that. And there's bibliotherapy as well, that people can get instructions through going and reading books on how to help yourself grow, to change your mindset to believe that you can do it.
I think that's a perfect way to finish off, and I think can we put our hands together through the excellent speakers?